Today, we're jumping into a real high-stakes challenge, something every medical professional has to master, figuring out the cause of acute intoxication, and fast. This is all about recognizing patterns, or toxidromes, a skill that's absolutely critical when the clock is ticking, both on exam day and definitely in the ER.
So, let's put your diagnostic chops to the test. Picture this, you're in the ER. A patient rolls in, altered, unstable, and you have to make sense of the chaos. We're going to run through a few quick-fire cases based on classic clinical signs. Your job? Try to nail the substance and think about what you do first. Ready?
Okay, let's get right into our first case. The patient you're seeing is just wired. We're talking high energy, high distress. So what are we seeing? They're agitated, their heart is racing, blood pressure's through the roof. They're talking big, acting grandiose, and clearly haven't slept in a while. Look at their eyes, the pupils are huge. But here's a huge clue, a really specific physical finding: skin excoriations. Those are signs that they've been picking at their skin, which often points to drug-induced hallucinations.
Okay, take a second. This is your classic upper toxidrome. Everything is revved up. What drug class fits this picture perfectly?
If you were thinking amphetamines, you absolutely nailed it. This is a textbook stimulant toxidrome. Now for your immediate priorities. Of course, you've got your ABCs: airway, breathing, circulation. But right after that, you've got to get that agitation and hypertension under control. And your go-to for that is usually benzodiazepines. And hey, for a quick memory aid, just think amped. Agitation, mydriasis, that's the dilated pupils, pressure up, excoriations, and delirium. All right, let's shift gears completely for our next case. We're going from one extreme to the other, from way up to way down. So with this patient, they're sleepy, they're unsteady on their feet. That's ataxia, that lack of muscle coordination. They're also having a hard time remembering things. But the most important piece of the puzzle here is the clear depressant effect, especially that really concerning sign of mild respiratory depression. So what's the common thread here? You've got sedation, you've got poor coordination. This is a super common presentation in the ER. What's causing it? Yep, this is classic for benzodiazepine intoxication. And your number one priority? Protecting that airway. You see mild respiratory depression, but that can go south fast, especially if they've mixed it with alcohol or another depressant. So you're watching their breathing and O2 sats like a hawk. A little mnemonic for you, think benzo. Breathing suppressed, eyes are often normal, nodding off, ZZs for somnolence, and out of it for amnesia. Now for a case that is tricky. It's got some features that overlap with stimulants, but with a few unique and frankly very dangerous twists. Okay, really pay attention to this combination. You get the euphoria, sure, but you also see this intense teeth grinding, which is called bruxism. And then you have the true life threats: a sky-high body temperature, high blood pressure, and a dangerously low sodium level, or hyponatremia. That last one is often from drinking way too much water. So what's the giveaway here? Those two things together, the crazy high temperature and the teeth grinding, are giant flashing red lights pointing to one specific synthetic drug. What do you think? That's right, we're talking about ecstasy, or MDMA. And let me be clear, that hyperthermia is a full-blown medical emergency. This patient needs to go to a critical care area now. Your first priority is aggressive cooling. We're talking ice packs to the groin and armpits, misting with fans, whatever it takes. This isn't just a fever. Their whole body's thermostat is broken. And this brings us to another huge risk. Ecstasy can kick off something called serotonin syndrome, which is basically a toxic flood of serotonin in the system. That hyperthermia we just talked about, it's a hallmark of this incredibly dangerous complication, and it needs immediate, aggressive management, starting with sedation, usually with, you guessed it, benzodiazepines. All right, our final case. This one really shows how a single, specific physical sign can blow the case wide open. Sometimes the answer is literally staring you in the face. So here, you've got the psychological stuff. Paranoia, time feels like it's slowing down. But it's paired with a super obvious observable sign: conjunctival injection. Or in plain English, really red eyes. So you put all that together, but you give extra weight to that key physical finding. What's your final diagnosis? This clinical picture just screams acute marijuana intoxication. That conjunctival injection is one of the most reliable signs you're going to get. Now, this isn't usually life-threatening, but the paranoia and anxiety can be pretty intense. So your main job is providing reassurance in a calm, quiet environment. Okay, this comparison right here is incredibly high yield. You got to know this for exams and for the clinic.
Both amphetamines and marijuana affect the eyes, but in completely different ways. Amphetamines cause the pupils to get huge. That's mydriasis. Marijuana makes the whites of the eyes red. That's conjunctival injection. Dilation versus redness. Burn that into your brain.
So, let's wrap this all up. We're going to bring everything together into one clean, high-yield tool that'll help you lock these patterns in for good.
Think of this as your cheat sheet. When you see agitation and dilated pupils, your brain should immediately go to amphetamines. Somnolence and ataxia, benzodiazepines. That deadly combo of hyperthermia and bruxism, think ecstasy and start cooling immediately. And if the big giveaway is red eyes and paranoia, you're likely dealing with marijuana. Mastering these core features is everything.
And that's really the bottom line here. Learning to spot these toxidromes isn't just some academic exercise. In a real emergency, with a real patient in front of you, it saves precious time, it points you to the right treatment, and it absolutely directs life-saving care. So, I'll leave you with this to think about. In the middle of a chaotic ER with a patient who can't tell you what happened, which one of the physical signs we just talked about do you think is the most telling? Which one gives you the biggest, fastest clue to what's really going on? Chew on that. Thanks for watching.